Welcome to Omnicurious Originals. We are celebrating the Diabetes Awareness Series, and today we have Dr. Padmashri Gulati with us. Dr. Padmashri Gulati is the consultant physician with special interest in cardiodiabetes and Doppler studies. She is currently a senior consultant in Gulati Eye Hospital and Medical Care Center. She is also an honorary visiting specialist in internal medicine of Railway Hospital in Jhansi. She has been involved in multiple presentations and has been on the scientific chair in various national and international conferences. She is also actively involved in organizing various health awareness camps, walkathons, and CMEs. She has been honored with the fellowship of the UP Diabetes Association and Seva Shri Samman by Madhu Chintan. We are very pleased to have her today with us. Welcome, Dr. Gulati. The stage is all yours. You may please begin.
So I'm going to speak on improving cardiorenal outcomes with new antidiabetic medications, dawn of a new era. As we know, diabetes, heart, and kidney are interconnected. Diabetics are predisposed to heart failure, and heart failure predisposes to diabetes. Diabetics are also at an increased risk of ASCVD. There's also a cross-connect between kidney failure and heart failure. About 1/3 of the patients of heart failure at the time of diagnosis have kidney disease. Worsening of kidney failure worsens heart failure and vice versa. Thus, for comprehensive management of diabetes and improving cardiorenal outcomes, it's very essential for us to focus an attention on heart, vascular system, and kidneys, in addition to controlling diabetes. As we all know, diabetes is a harbinger of cardiovascular disease. It's 2 times more common in diabetics. It occurs 10 to 15 years earlier in diabetic patients and it leads to 52 to 80% of death in diabetic patients. Thus, cardiovascular risk reduction in diabetes is of paramount importance. The conventional anti-diabetic drugs that are available in the market, they take care of glycemic control only. Recently, evidence from the recent CVOTs, two new classes of drugs, SGLT2 inhibitors and GLP-1 receptor agonists, have been found to show improvement in cardiorenal outcomes. And these results are now translated into guidelines for diabetes and heart failure. Thus, though metformin continues to be recommended as a first-line drug for type 2 diabetic patients with underlying cardiovascular risk or established CVD must be considered while selecting a second-line oral anti-diabetic medication. And GLP-1 receptor agonists and SGLT2 inhibitors are the preferred add-ons to metformin and lifestyle modification, with no preference for a specific agent within each class. If we look at the natural history of diabetics, lifespan is shortened by 6 years. If a diabetic patient develops myocardial infarction or stroke, lifespan is shortened by 12 years. These new classes of drugs, they also increase the longevity of the diabetic patients by reducing CV deaths due to ASCVD, heart failure, and CKD. Thus, GLP-1 receptor agonists and SGLT2 inhibitors have emerged as 2 pillars of diabetes as they take care of cardiorenal outcomes in type 2 diabetic patients. As a result of CVOTs that have been done over the last couple of years, SGLT2 inhibitors have emerged as a panacea for heart failure. GLP-1 receptor agonists, they reduce atherosclerotic events, and both the drugs have renal protection, though SGLT2 inhibitors score better than GLP-1 receptor agonist. When both these drugs are given to type 2 diabetic patients with a risk of CVD or kidney disease, they'll be benefited. But the problem with GLP-1 receptor agonist is, up till now, it had been available only in the injectable forms. With the recent therapeutic innovations and availability of the first oral GLP-1 receptor agonist, that is oral semaglutide, in the market, this problem has been taken care of, and we'll be able to prescribe these oral medications as well. Now, when you look at the RCTs with the new anti-diabetic medications from 2015 to 2020, all the 5 trials that have been done with DPP-4 inhibitors, that is Seva-Timi, Examen, Tecos, Caramilin, and Perlos, they show CV neutrality from point of view of MACE. But from point of view of hospitalization due to heart failure, Sexagliptin and Seva-Timi has been shown to increase in hospitalization of heart failure by 27%, which is statistically significant. Elogliptin in Examen trial shows 19% increase in risk of hospitalization, though it's not significant statistically. The trials that have been done with SGLT2 inhibitors, EMPA-REG outcome, DECLARE-TIMI, CANVAS, and DAPA-HF have all shown positive results in terms of cardiorenal outcomes. Recently, last month, we have results of soloist WHF trial with sotagliptin, which has been shown to have a positive result. Now, the 4 trials that have been done with GLP-1 receptor agonists, that is LEADER, SUSTAIN, HARMONY, and REWIND, have all shown positive results. Finally, 6 trial with oral semaglutide has shown to have positive results. As we know, heart failure in type 2 diabetic patients is caused by 2 mechanisms. Number 1, it's the atherosclerotic mediated diseases of the pipes that leads to myocardial ischemia or myocardial infarction, which results in myocardial scarring. And second is non-atherosclerotic mediated diseases of the pump, resulting in increased myocardial hypertrophy, fibrosis, stiffness, and diabetic cardiomyopathy. And these heart failure events, they lead to CV death in diabetic patients. And another 50% of death is caused by atherosclerotic MACE events. The awareness of atherosclerotic events in diabetes is great, and these problems are often taken care of by the doctors as well. The importance of heart failure, though, in diabetics is highly under-recognized. When we look at the role of SGLT2 inhibitors in heart failure, it has been shown that they lead to reduction in hospitalization of heart failure in high CV risk patients without heart failure, as is evident in EMPA-REG and DECLARE-TIMI trial. They also lead to reduction in CV mortality in patients with prior ACVD and in secondary prevention group. DAPA-HF trial is the first landmark trial to have shown to have substantially extended the benefits of SGLT2 inhibitors in slowing the evolution and progression of heart failure, particularly in patients with HFrEF in both diabetics and non-diabetic patients. And now people wonder if SGLT2 inhibitors will be having some protective mechanism in patients of heart failure with preserved ejection fraction. And we have various ongoing trials, DELIVER, DETERMINE, preserved HF with DAPA, and IMPERIAL-P and IMPERIAL-Preserved trials with EMPA, and we are waiting for the results. But it's anticipated that these trials may come out to be positive, as these drugs are found to be effective again on reduction of on improving cardiorenal outcomes through a non-neurohormonal pathway. So this is the data of the first 3 landmark trials of SGLT2 inhibitors, EMPA-REG outcome, CANVAS, and DECLARE-TIMI, and all these trials have shown to decrease hospitalization and heart failure in patients at risk. If you look at the meta-analysis of CVOTs in terms of hospitalization of heart failure, they decrease hospitalization and heart failure in both the groups, primary and secondary prevention group. And this is very important because every hospitalization and rehospitalization for heart failure takes a patient closer to death. The meta-analysis of CVOTs from atherosclerotic point of view, they lead to secondary prevention is beneficial in terms of MACE, but not primary prevention, as is evident in this slide. Thus, DAPA-HF trial 2019, as we all know, is the first large landmark trial of SGLT2 inhibitor DAPA, which has demonstrated a convincing effect of SGLT2 inhibitors to reduce MACE in patients with established heart failure. When we look at the data, about 4,744 patients were enrolled, and the age of patients for more than 18 years, and both the patients with or without diabetics were enrolled. Patients with ejection fraction less than 40% were enrolled, and patients had elevated serum markers. In one group, dapagliflozin 10 milligrams was given on top of standard of care treatment for heart failure, and another group received placebo treatment along with the standard of care medicine. And within a short period of 18 months, there was statistically significant reduction in the primary endpoints, that was CV death or hospitalization due to heart failure or an urgent heart failure visit. As we see in this slide, there was about 26% reduction in primary endpoint, 17% reduction in all-cause death, and it also led to improvement in quality of life of the patients, as is evident in the KCCQ bar chart. Dapagliflozin significantly reduced the primary composite endpoint of CV death or worsening heart failure on top of standard of care by 26%. And the effect of DAPA on the primary composite endpoint was generally consistent across many pre-specified subgroups, whether the patient had type 2 diabetes at baseline or no diabetes, EGFR less than 60 or more than 60, whether MRAs were given at baseline or no MRAs were given at baseline, whether the patient was in NYHA class 2 or 3 or 4, whether ejection fraction was less than median or more than median, serum markers whether less than median, more than median, or patient whether they had atrial fibrillation or no atrial fibrillation at the time of diagnosis. And the effect was consistent across other subgroups as well, like age, sex, race, geographical distribution, whether patient had history of prior hospitalization for heart failure or no hospitalization for heart failure, whether patient had ischemic or non-ischemic heart failure, BMI less than 30 and more than 30. The worsening heart failure component of the primary endpoint resulted in 30% reduction with DEPA. It prevents hospitalization of heart failure consistently regardless of baseline CV disease, whether there is history of ASCVD or no ASCVD, history of prior MI or no prior MI, history of heart failure or no prior heart failure, history of reduced ejection fraction or preserved ejection fraction, or patients with EGFR less than 60 or more than 90. The CV death component of primary endpoint resulted in 18% reduction with dapagliflozin. And the CV benefits of DEPA start very early and NNTs are small. The biggest victory with DAPA-HF trial is that this drug is effective in non-diabetic heart failures as well, in addition to diabetic heart failure with 27% risk reduction. So after the results of these trials were out, people were speculating if it would produce hypoglycemia in non-diabetic patients, if SGLT2 inhibitors be combined with ANI, or if there be any incremental effect on ANI. So will they produce hypoglycemia in non-diabetic heart failure? And the answer is no, because non-diabetics do not have glycosuria. Can it be combined with ANI? Is there an incremental effect? And the answer is yes. The drug is found to be useful in both the groups, and there was 25% and 26% risk reduction. This has opened up a new pathway for heart failure as it does not act through the neurohormonal pathway. When we looked at the comparison of results of DAPA-HF with ARNI paradigm heart failure trials, the reduction in primary endpoint with ARNI is 20% and with DAPA is 26%. CV death reduction with ARNI is 20% and DAPA is 18%. And hospitalization due to heart failure or worsening of heart failure, there is 21% reduction with ARNI and 30% reduction with DAPA. Thus, both the drugs are very good and powerful drugs. And peculiar feature of DAPA is that it has shown benefit on top of the standard 4 drugs which are used in heart failure. So the message which has come out after the DAPA-HF trial is loud and clear. DAPA is the first SGLT2 inhibitor which is beneficial in HFrEF and non-diabetics along with diabetic patients. It has additional benefit on top of ARNI because mechanisms of both the drugs are different. With DAPA-HF, a new era of medical management of heart failure has erupted. During last 5 years, we have 2 new drugs that improve CV mortality in heart failure on top of all standard medication. Data is strengthened by the positive results of Soloist WHF trial, the results of which were out last month in November 2020. And we are anticipating a positive response in the awaited DAPA trials in patients of heart failure with preserved ejection fraction. Thus, DAPA has been first approved by Canadian guidelines in 2019 and later it's accepted by other guidelines as well. So the next question is if SGLT2 inhibitors be beneficial in heart failure with preserved ejection fraction patients. It's been found that SGLT2 inhibitors, they act through non-neurohormonal pathways, whereas all the drugs that had been given in heart failure with preserved ejection fraction, the earlier drugs they used to act, they act through neurohormonal pathways. SGLT2 inhibitors, they lead to tubuloglobulin feedback, interstitial fluid loss, which in turn leads to improvement in congestion, not without affecting the organ perfusion. And these two actions combined with enhanced glycosuria, increased ketone metabolism, and fasting mimicry lead to reduced myocardial inflammation and cardiac fibrosis. Thus, cardiovascular outcome trials have shown considerable improvement in heart failure hospitalization and other CV outcomes in people using SGLT2 inhibitors. There are currently no treatments demonstrating mortality benefit for people with heart failure and preserved ejection fraction. And the EMPEROR trials will considerably add to our understanding of the future role of SGLT2 inhibitors in people with heart failure, particularly with preserved ejection fraction. Do SGLT2 inhibitors also provide renal protection? And the answer is yes. If we look at the first 3 trials of SGLT2 inhibitors, DECLARE, EMPEROR, CANVAS, they all have shown excellent benefit in terms of various renal endpoints. And the renal composite patients with and without atherosclerotic CV disease, renal benefits of DAPA equally extends to the primary prevention group also. When we look at the meta-analysis of SGLT2 CVOTs, renal composite outcomes by renal function, renal benefits of DAPA are seen across EGFR and albuminuria categories. If we look at this slide, which is showing the projected effects on EGFR based on Credence data, as we all know, in majority of the type 2 diabetic patients, there's a decline in EGFR of around 10 ml per minute per year. The introduction of RAS inhibitors in 2005, this decline came down to 4.59 per year. After the introduction of SGLT2 inhibitors, this decline in EGFR from 10 ml per minute per year has been brought down to 1.85 per year. Thus, SGLT2 inhibitors have made a revolutionary change in the management of patients with diabetic kidney disease, with decline in EGFR from 10 to 1.85 per year, thus curtailing the need for dialysis or renal transplant and also improving the quality of life. If we look at the trials of SGLT2 inhibitors in DKD or CKD, we all know that DAPA CKD has been prematurely terminated because of the immense benefits, and this trial was done in diabetic and non-diabetic CKD patients. We are awaiting the results of EMPA kidney trial, which also has enrolled few type 1 diabetic patients as well. So these are the number of putative mechanisms to explain cardiorenal protection which SGLT2 inhibitors offer. They act on kidney and they cause afferent arteriolar constriction, decreasing intraglomerular pressure. They lead to decreased intravascular ECF volume that leads to increased hematocrit and decrease in systolic blood pressure. This leads to reduction in preload, afterload, and LV wall stress that improves filling conditions, and this leads to improvement of myocardial energetics. They block NHE1, which contributes to cardiac remodeling and heart failure. As is evident in this slide, SGLT2 inhibitors may differentially regulate the interstitial and intravascular volumes. They predominantly lead to reduction in interstitial volume in contrast to loop diuretics that lead to reduction in both interstitial fluid volume and intravascular fluid volume. And this larger reductions in interstitial fluid volume is the reason why they prevent harmful effects of excessive blood volume depletion, including neurohormonal activation. This is the EMPA heart study that shows the reduction in LVMI, and it's also accompanied by significant reduction in ambulatory blood pressure. Thus, SGLT2 inhibitors are a unique class of therapies that show beneficial effects across the CV risk continuum in patients with type 2 diabetes. They decrease systolic blood pressure, they lead to reduction in body weight, reduction in HbA1c, this leads to reduction in clinical risk factors, they lead to regression of kidney disease, that leads to reduction in kidney disease, they lead to reduction in 3-point MACE, reduction in hospitalization for heart failure and all-cause hospitalization. They also lead to reduction in mortality and all-cause mortality. So SGLT2 inhibitors are also associated with some side effects, and genital infections are more common. And if we see the favorable effects of SGLT2 inhibitors in terms of prevention of heart failure, preservation of renal function, reduction in MACE, reduction in blood pressure, weight loss, and improvement in glycemia, these favorable effects are far more than the unfavorable effects of genital infections that can be taken care of by improving genital hygiene. SGLT2 DAPA has done the formidable task in improving CV outcome in HFrEF on top of 4 pillars of existing treatment. Therefore, it's a new weapon in the armory to fight the devil of heart failure. Thus, DAPA-HF trial, it's a momentous victory in the war against heart failure, and DAPA has emerged as the 5th new pillar for patients of HFrEF in patients with or without diabetes. So the message that has come out from the DAPA trials, in addition to DAPA being the first SGLT2 inhibitor, which is beneficial in HFrEF and non-diabetic patients as well, DAPA CKD trial has been prematurely terminated because of immense benefit and is a big milestone as it has shown benefits in non-diabetic CKD patients as well. Results of a pre-specified analysis of DAPA-HF trial found that DAPA reduced new onset diabetes by 32% in patients with heart failure. And the nephroprotective effect of SGLT2 inhibitors is beneficial in patients of heart failure, probably because of cardiorenal syndrome. So the question arises that whether SGLT2 inhibitors are the future of heart failure. So the results of Emperor Preserve and ART trials are awaited. and they will provide novel insight into the use of EMPA for people with heart failure with preserved ejection fraction or reduced ejection fraction. Additionally, they will improve our understanding of the impact of SGLT2 inhibitors on changes in renal functions and the use of SGLT2 inhibitors to prevent diabetes. Therefore, the results of these trials will add significantly to information on this subject gained from previous trials and hopefully provide novel therapies for people with heart failure to improve current clinical outcomes, which are all too often poor. Which has been introduced an anti-diabetic drug. There's a tug of war between cardiologists and nephrologists, but the diabetic patients, which often have a cardiac and a renal component also, the patients are going to be benefited by these drugs. There are two new studies providing a boost to the use of SGLT2 inhibitors in two very distinct patients population. Adding more data to SGLT2 inhibitor story have been released last month in November 2020, and is the result of sotagliflozin, SCORED diabetics with CKD and soloist WHF diabetics with decompensated heart failure. Both the trials were presented in the month of November at the Virtual American Heart Association 2020 scientific sessions and published simultaneously in the New England Journal of Medicine. And they showed that there's statistically significant reduction in the risk of hospitalization of heart failure in patients with diabetes and CKD and decompensated heart failure. So this is the data of SCORED trial, and SCORED trials, it was done in patients with diabetes and CKD with or without albuminuria, and SOTA it resulted in lower risk reduction of composite of deaths from cardiovascular causes, hospitalizations for heart failure, and urgent visits for heart failure than placebo. And this indeed has added one more feather in the cap of SGLT2 inhibitors in their beneficial effect in patients of diabetic CKD. So the next class of drug is GLP-1 receptors. As we all know, these drugs, they have a good glycemic control with minimal or no hypoglycemia. They decrease cardiometabolic risk by decreasing weight and blood pressure, and they decrease atherosclerotic MACE with renal protection. So these are the 6 injectable GLP-1 receptor are available in the market: exenatide, dexenatide, liraglutide, lvglutide, dulaglutide, and semaglutide. Now we have oral semaglutide in the commercial market as well, which has been approved by US FDA. So these drugs, they act through the 6 of the 8 ominous octet of defronzo. They improve insulin secretion. They lead to reduction in hepatic glucose production. They reduce appetite. They lead to increased glucose uptake by skeletal muscles. They lead to decrease in glucagon secretion, and they have increased incretin effect. Thus, GLP-1 receptor agonists, they provide a suitable option for an ideal anti-diabetic drug by addressing multiple pathophysiological defects of type 2 diabetes. These drugs, they offer glucose-dependent glycemic control with high efficacy in HbA1c reduction next to insulin, low risk of hypoglycemia, weight reduction, and other CV benefits. These are the potential mechanisms for CVD benefit of GLP-1 receptor agonists. They lead to increased cardioprotection, they decrease in coagulation, decrease in postprandial lipids, decrease in glucose, that is hypoglycemia. They lead to reduction in inflammation, reduction in body weight, blood pressure reduction, and increased diuresis and natriuresis. So these are the trials which have been done with the injectable GLP-1 receptors, and all have shown positive results. If we have a look on this slide, LEADER trial has shown 13% reduction in MACE, PIONEER trial 21 reduction, DIVINE 12% reduction, in HARMONY outcomes 22% reduction. CV death was reduced by 22% with liraglutide, and all-cause mortality was reduced by 15%. If we look at the PIONEER 6 trial, which has been done with oral semaglutide, it is shown to be leading to 21% reduction in MACE and about 50% reduction in CV death in all-cause mortality. Thus, CVOTs with GLP-1 receptor agonists with efficacious results in terms of MACE, CV death, and all-cause mortality reduction have led to a paradigm shift in the management of type 2 diabetes. If we look at the real-world data from Danish National Patient Registry, out of 66,000, which was done in 66,807 patients, when GLP-1 receptor agonists were added to metformin as a second-line drug, it led to 42% reduction in the risk of hospitalization. And this subgroup analysis indicates people at risk for CVD do benefit from metformin and GLP-1 receptor agonists in real world, which resonates with the findings of leader trial. But the problem with these medicines was these medicines GLP-1 receptor agonists were available in the injectable form. Now with administration of oral semaglutide, this is going to be very convenient for the patients and also for the doctors. So now we have oral semaglutide in the commercial market, which has been approved by US FDA. And this semaglutide is a peptide, and GI tract produces proteins that enzymatically digest peptides and proteins. SNAC protects semaglutide from proteolytic attack and facilitates absorption across the gastric mucosa. These are the results of Pioneer 6 trials, which are done with oral semaglutide, which was given in 14 milligrams of dose on top of standard of care patients, standard of care, and it was shown to have significant CV death reduction in the population. So although we have positive results of these trials, one wonders if we are adhering to the guidelines that has been recommended for these therapies. And it has been found that less than 7% receive optimal medical therapy in spite of 90% being on lipid lowering and CV medication. Less than 10% of the patients with type 2 diabetes and CVD are currently receiving guidelines recommended therapies for CV risk reduction, even in developed countries. If we take a deeper dive into the CVOTs, as has been discussed earlier, patients with type 2 diabetes have intrinsic myocardial disease, that is disease of the pumps, leading to diabetic cardiomyopathy, hypertrophy, fibrosis, and stiffness, leading to heart failure. And this subset of patients benefit more by SGLT2 inhibitors. There is another subset of patients which have diseases of the pipes, leading to myocardial infarction and ischemia. And these are the patients which are benefited mainly by GLP-1 receptor agonists. So these trials have been translated into guidelines, and these new guidelines have provided us with an altered roadmap. The clinical reluctance by the patients to be using an injectable preparation has been quashed by the US FDA approved oral semaglutide. These newer classes of drugs thus provide a comprehensive approach to diabetic patients by building two pillars and are also beneficial in non-diabetic patients as well. SGLT2 inhibitors have indeed added a feather in the cap and have dawned a new era for the treatment of heart failure. And these medicines have been incorporated in ADA guidelines 2020. And the GLP-1 receptor agonists are also endorsed by various other guidelines. So the take-home message is benefits of SGLT2 inhibitors are predominantly on heart failure and diabetic kidney disease. GLP-1 receptors benefit ACVD events and provide renal protection. An emerging combination is to be tried in future trials. Thus, we need to conquer CVD in diabetes, stop CVD in diabetic patients. Thank you.